Thank you very much for...
Yeah, okay. Our head, Professor Rinaldo, asked me to introduce the meeting, and this is developed by the liver group of the National Cancer Institute, and there are many HPB surgeons that take part of it. Dr. Rinaldo is the head, and this is a regular activity for scientific meetings. And Professor Paul Dag is from Norway. Everyone knows him in the HPB community, and we have invited him to talk about vascular techniques using transplantation that can be used in HPB surgery. Oh, it's on you, Paul. Go ahead.
So thank you very much, and it's great to see old Brazilian friends. I have a close connection with Brazil, and particularly Rio de Janeiro, where I was in 2015. So I'm going to share you my screen, and you have to tell me if it doesn't work. Let me see.
Just share screen on the bottom.
Yeah, I'll just find my. So this is here. You.
Achei aqui. Computador, tá?
Tá, mas tem que ser pelo YouTube. Dá 10 segundos de retardo. Aí fica complicado. É melhor deixar assim.
Okay.
Você pode. Essa tela não dá para encher. Só do YouTube.
Aqui, ó.
Mas o.
Do you see my screen now?
Yes, we do.
And you see it full size?
Yes.
Okay, very good. So what I'm going to talk about is application of vascular techniques in HPB surgery, and this is a big field and a lot of techniques, and I'm going to give you a flavor of the way we practice it here in Oslo. So why would we use vascular techniques in HPB surgery? Well, the prognosis for most patients with solid tumors is dependent on whether we can resect them or not, simply because the oncological therapy is hardly ever curative for most patients with solid tumors. So we have to rely on surgery. The other point is that although vascular invasion or affection of major vascular structure is often a sign that we are dealing with a very advanced disease, there is not always a very close relation between the tumor biological properties of a lesion and the anatomical location. In other words, some patients have unfortunate anatomy, but tumor biology that is okay. And the tumor location adjacent to main vascular structure may render the case non-resectable if you are going to use conventional surgical techniques. So we have to look for other techniques that make it possible to deal with these problems. So, for example, tumor A and B might be practically identical in biological properties. However, tumor A is a way more difficult situation to deal with than tumor B, where you can do a simple liver resection. So indications for these vascular techniques are mainly where radical resection will entail organ ischemia for prolonged time, or when we have tumor involvement of significant vascular structures that require resection and reconstructions. Another good indication is when we need a very extensive surgical exposure, and also in cases of multivisceral en bloc resections. So, an ideal platform for dealing with this is, of course, abdominal transplant surgery, because transplant surgery in general has elements of donor surgery, urology, gastro and HPB surgery, vascular surgery, and knowledge of organ preservation integrated. So it's an ideal platform to deal with this kind of problem, or at least if someone in the team has this experience, that's a great asset. So I'm first going to talk a little bit about pancreatic surgery and the way we do it here in Oslo. So traditionally, portal vein resection was not performed in the in the last century. There were very few. It has become increasingly common, and in Oslo, about 30% of the Whipples are now with vascular resection. And the reason is that the term borderline resectability has gained more and more recognition, and we have modern chemotherapy with FOLFIRINOX that allow us to select patients that might benefit from extensive surgery. And other very important notion is that those of you that are as old as I am know that in the old days, if you had a portal vein vein encasement, the normal surgical approach would be to try to peel the pancreas off the vein. This is not a good idea if we are going to do clean oncological surgery, and this study looked at this in detail. It's a study from Japan, and what they essentially did was that they classified the portal vein affection by radiology, and dividing it into type A, B, C, and D, depending on the severity of the narrowing of the portal vein. And at the same time, they looked at all specimens from these portal veins and looked at whether you had infiltration. So grade 0 is no infiltration, grade 1 is the adventitia, 2 is the media, and 3 is affection also of the intima. And it turns out that if you look at grade A, there are, of course, there is no narrowing, there is no infiltration, but already in type B, you see that there is a significant proportion of the patients having invasion in the vein wall. This indicates that if we want to do clean surgery or radical oncological surgery in patients where you have narrowing of the superior mesenteric or portal vein, you should consider and master the technique of doing portal vein resection and reconstruction. So what reconstruction techniques are we talking about? Well, on the portal vein and the superior mesenteric vein, most of these cases you can actually do a direct suture end to end, because when you remove the head of the pancreas, you will have additional length, allowing in most cases a direct suture. In some cases, the involvement is very limited and you can get away from it by just doing a patch pasty. And in other cases, quite rarely, you have to resect a large portion of the vein system, and then that might be dealt with interposition grafting. With regards to artery, this is fairly rarely indicated adenocarcinoma. I'll come back to that. But basically, it's a question of doing interposition grafting or reimplantations, or in very rare cases, patch pasties. So what kind of grafts do we use? Well, we wrote a review article about this last year. So the saphenous vein is well suited for arterial reconstruction, and you can also use it, of course, for patch material for the porta. A very good substitute for the porta is the left renal vein. You can use this in very select cases that have normal renal function, but then you have to leave the gonadal vein and the suprarenal vein in situ, so you don't get too severe congestion of the left kidney. Another elegant technique is the peritoneal flap. that was published by Safi Dokmak from Paris. I'll come back to that too. We also use, since we are a transplant department, we also use allogenic vein grafts and allogenic arterial grafts when needed. You might use bovine pericardium patch that you can buy commercially. We very rarely use synthetic grafts, and I don't like to use them because, as a vascular surgeon, I'm not very fond of putting vascular grafts, synthetic grafts, in a colonized field. And if you do a Whipple, you have a colonized field. So this is the Dokmak patch as it was published. You harvest parietal peritoneum from the diaphragm, and you can use it either as a patch or you can create a tube with it. So it's exemplified from the original publication. I have used it several times. Frankly, the falciform ligament is even better because then you don't have to care about which side you put into the vessel, because both sides of the falciform ligament are covered with epithelium that is tolerable. In reconstructions of the portal vein, like I said, the majority of patients can actually be dealt with an end-to-end anastomosis. I prefer to, if I have the option, I will usually reimplant the splenic vein if possible, because otherwise you get congestion, upper left side congestion that might cause some trouble. So if possible, I do reimplantation like this. Of course, in some cases you can do a patch or a interposition graft, but this is more and more rarely that we do, because in most cases it's possible to reconstruct without. I'll show you some examples of this. So this is, in fact, it might look like interposition graft, but it's in fact a patch placed here, and you can see it here. So the back wall where the splenic, inferior mesenteric, and the two main branches of the superior mesenteric vein, the back wall here is intact, so it's a simple patch prosty to reconstruct the bifurcation and all vessels in the region. Here is a larger resection. You see the pancreatic remnant here with the duct, and here is allogenic vein graft that is interpositioned between the porta and the superior mesenteric vein. With regards to arterial reconstructions, so the main indications is actually most often to repair or reconstruct a replaced right hepatic artery from the superior mesenteric artery, because when this will go through the back fatty tissue of the pancreatic head that is going to be removed, and very common this interferes with the oncological resection, so you have to resect it. I most often don't do it like this, but I rather connect the conduit to the celiac trunk. But you can do whatever is needed. So the main indication for arterial resection in our hands are patients with neuroendocrine pancreatic tumors. As you know, these have a much more favorable biology than the adenocarcinoma. So we have done a very, very few cases with pancreatic adenocarcinoma. It's of course technically possible, but most of the patients that have arterial involvement with adenocarcinoma have local very advanced disease, and the benefit of doing the resection is questionable in many of these cases. But in a few selected cases, you might consider it. So this is just an example of our own series of patients with neuroendocrine tumors where we did vascular resection, and as you can see, you can have quite nice survival outcomes, even though you have to do vascular resection in these patients. And this is an example of a patient with a neuroendocrine tumor. Here we have resected parts of the portal vein and done a direct end-to-end anastomosis. But the main affection in this patient was the artery. So the superior mesenteric artery has been resected with a segment, and this has been replaced with a saphenous vein graft. And the patient did very well. And here you see the hepatic artery, and the splenic artery will go here. My main work actually with vascular techniques have been in more complex liver surgery, and that's my main field of interest. So this is a much wider range of problems and patients. So the main indications are hepatic and perihepatic tumors, particularly when they involve the venous outflow or the hepatocaval confluence. Also tumors that involves the hepatic hilum. It might also be what we could term perihepatic tumors, meaning that they are not distinctly liver tumors, but they involve the retrohepatic vena cava. And of course, multi-organ resections where the liver is involved. And lastly, we have also utilized these techniques in severe vascular complications following liver transplantation. So there are some techniques that everyone should know about, and you probably all of you know about it too. So total vascular exclusion is one of these techniques where you selective make sure that you control both hepatic inflow and outflow, and this may be combined with hypothermic perfusion of parts of or the whole liver to extend ischemia tolerance. So just as an example, this was a patient I operated a number of years ago. He was a very young man with colorectal liver metastases. And this particular metastasis has a very close connection with the cava and a very close connection with the liver hilum, and is in contact with particularly the portal vein and the bile duct. So essentially, we would like to resect the right side of resection, but we would like to not have the portal vein, to resect the portal vein as well. So he was resected under total vascular exclusion with cooling, and we did not go this route. Instead, we approached the portal vein in the umbilical ligament, so-called Rex approach. So you put a bypass directly up to the left portal vein, so you can safely resect the hilum as long as you control the hepatic artery. And then we could do a Roux-en-Y on him as well. And that proved successful. But in very many instances, the former example is a fairly easy and not very complex case. The main problem are these more complex tumors. So this is a cholangiocarcinoma, and the typical problem is that some of these hepatic or perihepatic tumors, you can't really resect them with conventional techniques because you have affection of both venous outflow, you have affection of the vena cava, and you have affection of the hepatic hilum. So The portal vein is encased, the venous outflow via the right hepatic vein is encased, and the cava is totally surrounded. So the tumors like this really demands transplant surgical techniques, and I'll briefly go into two main techniques that can be used. And one of them is the so-called anti-cytum technique. This is not my, I don't use it very often. I use it only for strictly retrohepatic cava, when just parts of the retrohepatic cava is the problem, then it's quite a useful technique. Otherwise, I prefer to do full auto-transplantation for a number of reasons that I will come back to. So in the anti-cytum approach, we usually use veno-veno bypass. You might do it without veno bypass by using a portocaval shunt temporarily. But I prefer to use veno-veno bypass, and the way you do it then is that you put you have to clamp the hepatic inflow, and you administer cooling via catheter into the portal vein, and then you cut the cava just below the diaphragm, and then you can rotate the liver up, and you get access to the hepatocaval confluence and the retrohepatic cava. But it's quite a narrow approach. So if there is a lot of complex work to do, I favor the next level, which is auto-transplantation. And my philosophy around auto-transplantation is that this is a way to convert a very difficult surgical problem into 4 well-known modules. So we know how to do total hepatectomy. I mean, we do it for a living in a lot of patients per year. So that's mostly not very difficult. So, and veno-veno bypass or porto caval shunting is standard of care, routine praxis. Next, doing preservation on the bench and bench preparation of the liver is also fairly easy. In fact, it's easier to resect in a bloodless field than it is to do it in vivo. And lastly, to transplant the liver back is also standard of care. So this is the main philosophy. If you have such a very difficult tumor, we think this is the easiest way to deal with the problem. Of course, there are so the main advantages you get very good ischemia tolerance. It doesn't matter if you require some hours of the ischemia, because the liver will usually tolerate it very well. You get wonderful access to every aspect of the liver, and you get extremely good conditions for doing more complex vascular reconstructions. The downside is, of course, that it is complex. You have to rely on veno-veno bypass, at least in my experience, that's the best way to do it. This increases the risk, the complexity, and the bypass. And the risk of complications is fairly high. But as I will show you, it can be done safely. So just to give you some examples, this was actually my first case. It's now 20 years ago. The patient was at this time 67 years old. He came with a history of back pain and swollen legs. And the CT showed a big tumor of the vena cava, obstructing both the cava and threatening to compress the hepatic outflow. So, and of course, this is not resectable by any conventional techniques. So we decided to do an auto transplant on this patient. Here is from the hepatectomy. You see the hepatic artery, and this is actually segment 1. If you see my pointer, segment 1, and underneath is the cava, which is swollen by the big tumor. So a total hepatectomy, taking out the cava, is the way to go. And here is the liver out of the patient. You see the cava with the tumor and the liver veins that are elongated and very stretched. So it's a fairly simple resection to get the tumor away. And then what is left is then the middle and left hepatic vein and the right hepatic vein. So we have to create a new vena cava. So the middle and left was reimplanted directly, and then a short interposition graft for the right hepatic vein and the cava reconstructed with a Gore-Tex prosthesis. Here you see the post-op imaging some few days after the operation, and this patient went on to live. He died in 2017. He had a survival time of 16 years before he died of old age. Another example, when you look at hepatic venous outflow, might also be a challenge. So this was a man born in 1951. He had undergone a previous left-sided liver resection for cholangiocarcinoma, as you can see here, and that operation went well. It was done at a different hospital than ours, but he came back with this type of recurrence, and the problem, as you can recognize, you have the tumor sitting in between the main first bifurcation of the right remaining hepatic vein. And that's very difficult to resect with safe margins, because these tumors will usually infiltrate the venous wall. So what we did, we decided to do autotransplantation and extracorporeal surgery in the patient. So he was brought on veno-vena bypass. So we took out the liver with cava preserving technique, meaning we leave the cava in place and do portal caval shunting. And here you can see the opening of the right hepatic vein. And we preserve the liver. Then we plan to do this kind of resection, take the whole hepatic outflow and this portion of the cava out. And we did that with ultrasound guidance and a harmonic scalpel. And here you see the specimen. You see the main bifurcation, and when you cut that, you see how this tumor is hopelessly attached to the vein, and you couldn't possibly resect this without doing some reconstruction. And here is the cavity after the resection. Of course, the problem now is that we have altogether 6 liver vein openings, which is quite demanding to reconstruct. You can't do tubular grafting here. So what we did is that we had preserved the cava, so I removed half of the suprarenal cava and placed the Gore-Tex here. Then I took the cava and split it and used it as a giant patch. And then you simply reimplant all the liver vein openings into the patch, and then suture this back into the native cava that is remaining. And here is the outcome after reperfusion. And as you can see, this is immediately after the operation. This CT was taken much later, I think 2 years after the operation. And as you can see, he is completely tumor-free and has a nice cava with no problem. You see the graft, and here the outflow that is reconstructed. This patient lived on for 7 years. Unfortunately, he started to drink and got depressed and actually committed suicide after 7 years. But he lived well until he got his mental disease. Now I'm going to show you a much more advanced case. So this is a case with a big sarcoma of the vena cava as an example of perihepatic tumors. So what you can see here is that you have a large bulky tumor here that is essentially replacing the whole cava. So the whole cava is a big tumor, and it's extending from the lumbar portion all the way to the diaphragm. So this is also a case for autotransplantation. So here you see when we open the abdomen, you see some Norwegian texting here. You shouldn't bother with that. So here you see the tumor covered by the peritoneum that we are freeing up and mobilizing. So the idea here is to take out the whole abdominal cava and the liver and the right kidney, which is involved, as one piece. So here we have the lower cava that is not affected by the tumor. Here is the big sarcomatous tumor. So this is a big undifferentiated leiomyosarcoma. So the patient is again put on bypass, and then we cut the porta and just let that bleed out, because it's blood that is going to be removed anyway. So the liver goes out together with the cava and the kidney. So this is back table preparation. You see we preserve, infuse and cool the liver. And here you can see the right kidney and the cava tumor in one piece. So the right kidney had to be removed because it was too close. So, but the dissection on the back table is very easy. It's no big problem to do. And in the meantime, I make a portocaval shunt simply by doing a direct anastomosis between the terminal cava and the porta by using an allograft. You can see it here in the middle of the picture. So in this case, we didn't have to cannulate portal system. So here is the resected specimen, and here is the liver. And then we bring it back to the patient again. You have the liver isolated from, so we had a venous outflow here with the left and right liver veins. And then we have to make a new cava and implant the liver veins into the cava again. In this case, we use the Dacron prosthesis, and then this is as a routine liver transplant. It's placed back into the patient, and here you can see. I think this is probably the reperfusion. Yes, here we have the portal anastomosis done. So the remaining thing to do here is the arterial anastomosis, which I don't think is in the film. So she did well for 5 years. She had a recurrence. They have a tendency to recur. She had a recurrence after 6 years and lived on for 7 years, which is a good outcome compared to a total inoperable state. As an example of something of the same, but even more complex, is this gentleman. He had a similar tumor. It proved to be an undifferentiated sarcoma starting in the left renal hilum, extending all the way up in the cava and into the atrium. So he was treated at another hospital on the West Coast, and they, of course, said he was inoperable, and they gave him some chemo, and they even gave him radiation, which is normally not indicated in these patients. But he had a slight response, and he lived on. And after 1 year, they referred him and asked if we would consider to operate him. In the meantime, he developed occlusion of the whole cava, extending into both common iliac veins, as you can see here. And of course, we looked at this, and we thought the most likely thing was that this is thrombotic occlusion rather than cancer, because they commonly don't grow against the bloodstream. So with that in notion, our plan was to remove left kidney, right kidney, cava, and liver en bloc, and do back table as I showed you in the previous case. We did an investigation of renal function before the operation, and it turned out that he had his best kidney was the left. The right kidney was rather bad, having only 30% of total renal function, which was a concern. So we removed this amount of tissue en bloc. Before we removed it, we took a frozen section here, and that was negative. And basically, what we ended up doing was, since you have no cava, we sutured the venous outflow directly to the atrium. We had to resect segment 1 because of radiation and tumor. And then, since I don't have a cava, I auto-transplanted the right kidney, and I did end-to-end artery anastomosis and end-to-end urethral anastomosis, but we had to put the renal vein to the portal vein, because there is no other vein we can drain into. And this patient is still alive. It's now 7.5 years old after the operation. He's completely free of tumor. His problem now is renal failure, and he has, in fact, asked me if I can do a renal transplant. I think that is going to be difficult. So in the literature, these procedures, auto-transplants, they were done. The first one who started this was Pichelmeier in Hanover in 1998. He reported a series together with Schlitt. And as you can see, they had a fairly high mortality. This, of course, has to do with patient selection. They had high rates of liver failure, and they had to allotransplant some patients. And this has been more or less the literature. There are a few centers that have big experience with this. Oldhofer in Hamburg has also worked in Hanover with Pichelmeier, but did later go on to do a series of it on his own. Still the same results. Lately, the Chinese has introduced this technique as a way to deal with alveolar echinococosis with excellent results compared to allotransplantation. That would be the alternative. So this is quite exciting. This is, however, a completely different group of patients. I do not have any experience with this because this disease is very infrequent in Norway. So, but basically since 2001, since the first guys I showed you, we have done 33 cases with a median age of 48. There has been 15 primary tumors, 12 metastatic tumors, 3 benign tumors, and 3 of them were complications to liver transplantation that needed more extensive care. So in all patients, we have done vascular reconstructions with particularly vena cava, but also often the hepatic veins. We have had a range of complications, as so the morbidity rate is quite high, but the 90-day mortality is just one patient. So the 90-day mortality is about 3%, which is much better than reported elsewhere in the literature for these indications. And if we look at survival over time, patients with primary tumors do quite well, about in the range of 50% 5-year survival, whereas for metastases it's worse, and this is of course what you would expect, because metastatic disease has a worse survival than primary tumors. This is the same curve actually, so I had double slides there. So if I were to conclude, I was supposed to talk about 40 minutes. I think I'm just on time. The conclusion is that you can utilize transplant surgical techniques with vascular reconstruction in HPB surgery. It's both feasible and it's safe. It's good to have some training in vascular surgery or transplant surgery as part of the team, but not everyone need to do it. But part of the team will benefit greatly from having some training. But one piece of good advice is that if you go into this field, you might feel very powerful, and having a powerful surgical toolbox might tempt you to do a lot of very demanding operations and try to repair anything. You have to remember that tumor biology is the king, the anatomy of the patient is the queen, and what we do for surgery are merely the prince and the princesses. So surgery may overcome mainly unfortunate anatomy, but you cannot really solve the problem of aggressive tumor biology by surgery. So this hints at, if you're going to do vascular techniques in HPB surgery, critical patient selection is crucial, and by all means you have to avoid heavy comorbidities, cholestatic livers, and patients not responding to chemo. These are not very good patients for these kinds of procedure. So with that, I give you some clips from where I grew up in Norway, and thank you very much for the opportunity to talk to you and for the attention.
Os comentários antes de abrir para perguntas da plateia. Well, what can I say after your presentation? It's fantastic. You have spared us a very special case, which I expected to see today, which was one case you had to resect the venous confluence and use part of the pericardium and reimplant the liver in the right atrium itself. Do you remember that one?
Yeah.
You spared us that one. It's a beautiful one.
Yeah. Yeah, I have done a selection. Yeah. So I also have some videos that, but some of it is not edited good enough, or so. But we are going to present this work at the European HPBA meeting in Bilbao in September. So and we are just now writing a paper about it.
Yeah, but your lecture has been very inspiring. Your royal family, you're the prince, we're still peasants. Yeah. I mean, it's very inspiring in the sense that we as HPB surgeons, we are responsible for some results. And the extension of resectional capabilities is very important to progress in the field of vascular surgery and some transplantation techniques. We have some questions here, some comments in the chat, and let's.
Yes.
First, I'm going to open the questions to the audience. Alguém aqui tem algum comentário, alguma pergunta?
Como que ele vê a reconstrução da veia esplênica, quando ele ressecou a porta e precisou reimplantar CCT? Ele fala mais ou menos aí que nem sempre ele reimplanta. Mas qual é o resultado dos pacientes que ele não reimplanta? Se teve sangramento gástrico?
Paul, our boss here, Rinaldo, is asking you a specific question on splenic vein reconstruction.
Yeah.
When you do not reconstruct, and what are the results for not reconstructing?
I haven't looked at that specifically and compared the patients. So what I rarely, I always reconstruct if I can do it. If there is no particular reason not to do it, there are two main reasons. One is that you avoid the congestion, but the other reason is that the higher flow you have in your reconstructed segment of the portal vein, the better it is. So we always do it. So if but of course we have some cases where this is not feasible, and then we just ligate, and most of the time it goes well. But I'm in my surgical thinking, I'm always trying to look for perfection, meaning that I would rather select a technique that gives me good results in 96 of 100 cases rather than 92 of 100 cases. If you understand what I mean. I think the optimal thing to do is to reconstruct if possible. If it's not possible, well, then ligate.
Well,
I see that Ronaldo Andrade, who stayed with us in Oslo some years ago and is a good friend, he asked for other tips to check leakage before reperfusion. Yes, this is an excellent question. So what we use is that if you do cooling and you have total ischemia and you do a resection, a very neat trick is to take parenteral infusion solution and have it cooled, and then you infuse this into the artery or porta or bile duct, whatever, to check whether there is leaking milk-like substance. And the advantage of this as compared to water that you can't see, or blue dye that you can see only once, because if you use blue dye, you see it very clearly, but if you are going to do repeated checks, there is no value. So this is a very neat trick. Use intravenous parenteral nutrition, intralipid or something like that, and then you can just wipe off and do it as long as you need. The only thing you have to do is if you use it in bile ducts or in the vascular, you should rinse by infused cooled saline before doing the anastomosis. But that's a wonderful technique.
Paul, among your cases, most of the time you reconstructed the vena cava.
Yeah.
But in some sarcoma disease, most of the time there is already a bilateral net of venous return.
Yeah.
So in which cases would you reconstruct or not reconstruct? Just focusing this collateral bypass natural network.
So that's also a very good question. So in patients that have developed big collaterals, you might consider not to reconstruct. And the case I showed you where I put the renal vein into the portal vein, he had totally thrombosed cava. He had no edema. There was no point of doing a reconstruction in that patient, so we didn't do it. So that's a typical example. But a lot of the other patients have symptoms. So if they have symptoms, I will usually reconstruct.
Well, Yes. Well, before we finish, but we still have a lot to talk. But before we finish, I would like already to extend to you another invitation, and another invitation for a future talk, in which you would give us technical details of liver cooling and liver bypassing, because I remember we had a talk in which you said you usually use the biopump bypass because it's very easy for you. You have it available. But when we discuss on a case-by-case basis, not all patients need a bypass. Or there are simpler solutions like passive veno-venous bypass, right?
Yes. Okay. So there are options. So like I said, when my philosophy with the auto transplant technique is that I try to convert these patients into patients that look like transplant patients. So I divide them into modules. I do the hepatectomy, I put them on bypass, I do the bench preparation and preservation, and then I do transplant. So regardless of what tumor it is, it can sort of be converted to something that I know. Because the problem in these very rare cases is that if you have to invent the operation as you go, the likelihood of problems is much bigger. That's why I tend to try to stick to a standard whenever possible. So, but since we don't use veno bypass very often in routine transplant, but I have used it for so many years, so it's very easy for me. But I think it's possible to do one elegant technique. One elegant technique one can use is that if you do a total hepatectomy and remove the cava, you can quickly do a total clamping of the cava. Then you put in a synthetic graft in the cava position, and then you do a portocaval shunt. Then you don't need a bypass. So that's possible to do as well.
Well, we have changed the position of the camera for you to have a look of our audience. Most they are our surgical staff and residents. And we have here at least 3 which have performed transplantation surgery. I would like to raise your hands. Estuduto, levanta a mão, por favor. And Rinaldo here, our boss, and Carlos Eduardo sitting right beside me here, okay, and which is your close friend.
Yeah.
Okay, and if tem alguma pergunta, Estuduto? Algum comentário?
Eu só queria, assim, se fosse possível, que ele falasse alguma coisa em relação à preferência de peritônio em relação à reconstrução vascular total ou parcial. Se ele usa mais quando ele vai fazer a reconstrução de vaso, como ele fez ali naquela técnica em que ele colocou uma prótese para poder voltar, ou se ele faz com enxerto, porque lá eles têm banco de vasos, que a gente não tem aqui, né? Então,
se ele prefere enxerto ou peritônio? Pode ser a pergunta?
Pode ser.
Okay. Soduto has asked, which one do you prefer? When you need a total vascular reposition, not reconstruction, would you prefer peritoneum or a graft or a synthetic graft?
I would probably do peritoneum, depending on the indication. But I can accept synthetic grafts in liver if we don't do any bowel preparation. So if I'm not going to do a Roux-en-Y and it's plain liver surgery, I can accept synthetic graft. But I mainly try to use biological material because I think there is. I have seen some cases of infections with the synthetic grafts, and so if I can avoid it. Besides, I think the synthetic grafts are more thrombogenic. I didn't say that, but we use low molecular weight heparin in every patient post-operatively for 14 days at least. As soon as they are over the first surgical phase, we put every patient on aspirin, 75 milligrams. And during the operation, we also use heparin bolus before we put the clamps on. So we are, because my philosophy here is that I'm much more happy to reoperate for bleeding than for thrombosis. Thrombosis is a bad news. Bleeding is usually manageable.
Another question for you.
Yeah, so which preservations? So we use IGL, which is very similar to University of Wisconsin solution. But you can, if you are going to do bench surgery or things like that, you can use any preservation solution. It doesn't really. The best one I think is IGL or UW. If you use UW, you have to flush it out before you reperfuse because it has high potassium. So that's a very important message. If you are going to do total vascular exclusion and just cool, you can use saline. Just for saline at 4 degrees is good enough. And then you can add some slush.
Excuse me, saline or Hartmann solution?
It doesn't matter. So routine intravenous fluids that are cooled are good enough if you're just going to clamp for 30 minutes or something like that and cool.
Okay.
Then that's sufficient.
Well, now it's time for us to stop. We thank you very, very, very much for your time, your precious time.
It's a pleasure.
Everyone, and everyone has commented it has been an excellent lecture. Thank you very much.
Pleasure to see you all again. I hope to see you again soon.